I think we are live now on Zoom, on YouTube, so that's good. Let's close this. Let's close this, and let's give us a couple of minutes for people to join, and then we can start. Perfect. Oh, I need to activate the, that's why there's no messages. Sorry for that. I think the messaging function is still not working, so I'll activate it now. Can you put anything on the chat or still not working? Still not working. Let me just see what's happening. Oh, it's working now. So let me make sure that all works okay. Participants. Perfect. Chat. More. Welcome, everybody. And it's great to see a couple of hundred people already online. The webinar today is different. It's not technical webinar. It's a non-technical webinar. It's about predictive and prognostic tools. And I think understanding those tools and oncology is very important for surgeons, not only for oncologists, because you need to treat the patient and you need to treat the whole cancer. So there's lots of things that are changing sometimes by the week, really. And what is current guidelines can become past guidelines quite quickly. We have fantastic speakers as usual. So we have Isaac Garcia Morales from ICR in London. He's going to talk about implementation of circulating tumor DNA. We have Johan Hartman from Karolinska in Sweden. He's talking about AI-based image analysis for genomic profiling. We have Tim Crooks from London. He's going to talk about genomics. We have Abir Shaban from Birmingham. She's going to talk about pathology. And we have two serial offenders, Andreas Karakatsanis and Peter Barry, for the discussion. We have two channels today. So welcome back, Ricardo. So Ricardo was not with us last time. We gave him the excuse because it was his daughter's wedding. So congratulations, Ricardo. We missed you last time. And we have Katya with us today. She's doing the Russian Spanish. So if you want to listen to the talks with the immediate translation in Spanish, please click on the, I think the options have changed slightly in the screen in front of you with Zoom. Just go on the translation and just choose the Spanish channel. And if you want to speak to listen to the Russian, you go to the Russian channel, and the talks will be all in English. We'll give the 4 talks, then will be followed by the discussion. And remember, there is 1.5 CPD points by the Royal College of Surgeons of Edinburgh for people attending. You will get the certificates. You don't need to email me tomorrow. It will take a week until you get things done. Try to enjoy the webinar, and hoping to see as many of you on future ones. So we'll start with the first talk, and we have Abir Shaban, who's going to give us the pathology update. Abir, the next 15 minutes are all yours. Thank you.
Thank you. Thank you all, and it's a pleasure to be here again. And I'm going to talk about the basics, what we can get out of pathology regarding predictive and prognostic tools. And just to start with, what's the difference between prediction and prognosis? So generally, prognostic factors are those that you can measure and that can correlate with survival. So prognosis depends on the natural history of the disease, while prediction is a measure of response to therapy. For example, endocrine therapy, immunotherapy, neoadjuvant chemotherapy. So the very basic, and it's a lot actually we can get out from the humble old H&E slide that and immunohistochemistry. So first we look at the morphology, which is the product of the underlying molecular events. And therefore, appearances generally reflect behavior and reflect the underlying genetic composition of a tumor. So great to start with. If they look different, they are different. So if you look at the left-hand side, this is a grade 1 tumor, while the right-hand side, this is a grade 3 tumor. They look different and behave differently. So grade is prognostic. And these are the three key prognostic parameters that we get from just looking down the microscope and assessing tumors on an H&E slide. So tumor size, nodal status, and tumor grade. And by far, the most important morphological prognostic factor is the nodal status. So positive or negative, and also how many lymph nodes are affected. As you know, we use this to calculate the Nottingham Prognostic Index. So grade and nodal status, as you see, are more important than tumor size. And this gives us three prognostic categories. 3.4 or less is good, and poor is above 5.41. And this translates into patient survival from 80% to up to 10% only. There are other features that we can get from looking at the tumors, and one of them is the concept of the low nuclear grade neoplasia family. So we have a number of precursor and in situ and malignant lesions that look similarly down the microscope, and they share the same molecular profile, namely the loss of long arm of chromosome 16 and gain of 1q. So they look similar. They have different risk factors compared with the high-grade disease. They respond better to endocrine therapy, and they have an indolent course compared with high-grade lesions. So basically respond to endocrine therapy with less response to neoadjuvant chemotherapy. And this is an example of what we call low nuclear grade neoplasia family. So that's one slide showing so many lesions. So flat epithelial atypia, low-grade DCIS, LCIS, tubular carcinoma, invasive lobular carcinoma. So all of these can coexist in one lesion. And this has led us to the recognition of the different pathways of breast cancer development, including the low-grade arm, starting with ADH and low nuclear grade DCIS, and the low nuclear grade invasive carcinomas, completely different from the high-grade pathway. As we all know, the routine test that we do by a simple and cheap immunohistochemistry on every primary breast cancer and also in recurrent and metastatic disease, we test for ER, PR, and HER2. And all these markers are both predictive of response to therapy, but also prognostic. So we know that ER and PR tumors are usually of the low grade and recur over a long period of time, whereas HER2 positive tumors are usually of high grade, recur early, and usually metastasize by blood. In addition, we do other tests such as FISH or DDISH to assess for HER2 amplification. And this is also predictive of response to anti-HER2 therapy and also prognostic. Morphologically as well, we can look at the heterogeneity of tumors, and we know that heterogeneity is important in response to therapy. So for example, this is HER2 showing areas of positivity and other areas that are negative, and this is not uncommon in HER2 assessment. And the same applies to FISH as well. We can identify areas of negativity with areas of positive or amplification. And this also predicts response to anti-HER2 therapy. Pathologists also provide you prognostic information by assessing residual cancer after neoadjuvant chemotherapy and also after neoadjuvant endocrine therapy. So one of the systems that we use is the residual cancer burden, and basically we measure the tumor size in 2 dimensions, assess the overall cellularity, percentage of in situ disease, and a number of node positivity and the size of large metastases. And this will give us the residual cancer burden and residual cancer burden class. We all know that PCR is prognostic, and tumors that achieve PCR provide a better prognosis for patients. And then we can arrange for what we do next if there is residual disease. So this all can be done just using H&E. In addition, we also know that neoadjuvant therapy can lead to change in molecular marker profile and the true tumor profile. So this is an example of a change of HER2 status from positive to negative following neoadjuvant chemotherapy, which is more common than a change from negative to positive. But they do change. So ER, PR, and HER2 can change in a small proportion of tumors, and that's why we repeat testing on residual tumors following pre-treatment, whether neoadjuvant chemo or endocrine therapy. In addition to that, we can provide some prognostic and predictive information by reusing all tests like HER2 immunohistochemistry by identifying new categories. So now we are aware of the HER2 low breast cancer, which is the HER2 1+ by immunohistochemistry or 2+ that is FISH non-amplified. And this represents a large proportion of breast cancer, over 50%, particularly more prevalent in the luminal phenotype, but it's a heterogeneous group. So it includes both the triple negative phenotype and the luminal phenotype. And this is important because now we can treat a majority of breast cancer patients, where previously with a binary classification, we were only focusing on the HER2 positive cancers, but now there is a treatment for those tumors that express very low levels of HER2. Other prognostic markers that we do, while Ki67 is not done routinely everywhere, but we know that it is prognostic and also predictive. As you know, Ki67 is a proliferation marker. High Ki67 proliferation is associated with poor histological prognostic features, such as high-grade tumors, large tumor size, and lymphovascular invasion and lymph node involvement. It's also associated with ER-negative tumors and HER2-positive cancers. It has been shown to be an independent prognostic indicator in many studies, and meta-analysis of 43 studies showed that Ki67 is associated with shorter overall survival and disease-free survival. And it's also associated with outcome in ER-positive breast cancer and independent in multivariate analysis. Ki67 is also predictive of response following both endocrine therapy and neoadjuvant therapy. So the baseline Ki67 is predictive of outcome, and Ki67 after NEAT is also predictive of outcome and whether patients need adjuvant chemotherapy or not. It's a component of what we call the PEPI score, which is a combination of age, nodal status, ER and Ki67, and those tumors with very low PEPI score can avoid adjuvant chemotherapy. And high Ki67 after neoadjuvant endocrine therapy also predicts disease-free survival in the IMPACT trial. The strength of data following chemotherapy is less than neoadjuvant endocrine therapy, and there are conflicting results. It has been shown, though, in different studies, such as the Nottingham series, to be predictive of chemo benefit if it is a very high expression, more than 70%. So you will notice that Ki67 has different cutoffs depending on what population you're looking at. Are you looking at chemotherapy or endocrine therapy? It also suffers from poor reproducibility in assessment and whether to assess the hotspots, the overall assessment, what antibody to use, whether to use image analysis or not. So that these all factors hindered its implication in routine clinical practice. Ki67 can be measured by percentage, and these are the various cutoffs used in the literature from 14% to 34%. It's component of PEPI score, PREDICT, and also the IHC4, but this was assessed by image analysis. So the lack of standardization has limited its routine use. Other companion diagnostics that came a bit later and are being used to predict response to immunotherapy is PD-L1. So this is an example of an invasive carcinoma with a lot of TILs, tumor-infiltrating lymphocytes. And in PD-L1, we don't look at the epithelium, we actually look at the immune component of the tumor. So we are looking at the stromal component, particularly using the SP142 assay, and we can look at the tumor and TILs in the second assay. And all of this came from the primary analysis of the trials looking at the SP142 atezolizumab, and that showed that there is improvement in progression-free survival in tumors that expressed PD-L1 positives. So the two assays that we use are the SP142, which is the Ventana assay, which is predictive of atezolizumab therapy, and the 22C3 assay, which is the DACO one, which is for pembrolizumab. The latter is licensed and FDA approved, and in the UK we do actually both assays and we use both drugs. Obviously, there is a lot of quality assurance that go with the two assays, including the controls, training, and assessment, and is currently done only in regional centers, not everywhere. And just to show you that the expression is not identical for both tests. So sometimes you get them both negative, both positives, but occasionally you get different expression where you have positive SP142 and negative 22C3 or vice versa. And that's why we test both antibodies to give the oncologist the option of choosing which drug or which immunotherapy regimen to use. Another thing to also keep in mind is the difference of expression by tissue and by the nature of the tumor. So it is more common in the primary tissue compared with the metastatic tissue. So if you have both, try and try one, and if it's actually negative, you can try the other. One thing to note as well is the expression is very low in liver tumors. So if we can avoid liver, if you have more than one metastatic site and you can avoid the liver, try to use either breast or lymph node. This is likely to be expressed, and also skin. One thing, again, that pathologists can provide is the profiling of metastatic disease morphologically and by doing receptors. And this is because there can be a discordance between the expression of primary and metastatic lesion. So at the moment, there is a lot that we do with a small amount of tissue, lots of prognostic and predictive markers, and we will hear later about the gene assays and genomics as well. In addition, we also can provide some prognostic information based on the morphology and expression of particular markers to diagnose very rare types of breast cancer. So this is an example of a bland-looking triple negative breast cancer. So not all triple negatives are high grade, and this is an example which is called tall cell carcinoma with reverse polarity, very similar to papillary thyroid carcinoma by morphology. And we can confirm the diagnosis by molecular testing. So if we test for the IDH2 P gene, we can identify a specific hotspot mutation to confirm that. If we confirm it, it's important because this is a good prognosis triple negative breast cancer that generally doesn't need neoadjuvant chemotherapy or adjuvant chemotherapy. Similarly, another tumor called secretory breast carcinoma is a very rare one, but it's important to identify, again, a triple negative one that is characterized by NTRK3 gene fusion. And this NTRK is one of the tumor agnostic genes, and if they are there is a therapy directed to it. So we don't only provide information about the prognosis, which is good in this case, but also about what treatment this tumor can receive. So this is the secretory breast carcinoma, and all these tests are available on the NHS directory, so you can look them up, and they are available for free in the UK. So lots of prognostic and predictive information: grade, NPI, nodal status, typing by ER/PR HER2, and we can add Ki67, multi-gene assessment, companion diagnostics such as PD-L1, repurposing all tests such as ER low positive and HER2 low breast cancer, and then integration of molecular and morphology to provide some information about particular types of rare breast cancer that have prognostic information. So it's important to know what test to use and at which indication. Important to provide user results very quickly. And obviously H&E and immunohistochemistry are the quickest and the most tested, something that stood the test of time. And to assess residual tumor after chemotherapy or in recurrent and metastatic disease, and advice on tissue handling. I leave you with some hopefully interesting reads in your spare time. And that's it from me. Thank you.
Fantastic talk. Thank you, Abir. It's great to have you again. For people online, because some people are saying that the voice came and went, please check that you are on the English channel. If you're listening to the talks in English, if you want to go on the Spanish, go on the Spanish channel, or there's also a Russian channel today. We'll take all the questions after we finish. There are a few questions on the Q&A section. We will have a look at them and see if we can answer that, and then we'll go live. The next speaker is Tim Crooks, and Tim is one of the oncologists that work with us in London. It's great to have him again. And Tim is going to talk about genomics in breast cancer. So Tim, the next 15 minutes are all yours. Thank you.
Yeah. It should work. 1 second. Is it on now?
Perfect.
Yeah. Good afternoon, and thanks, Yazan, for asking me to contribute to the workshop again. I'm going to talk a little bit about genomics, predominantly from a medical oncologist point of view, but there are a new quote unquote science transforming the way we manage breast cancer. I would say that genomics, genetics, DNA, call it what you will, is still not universally popular with oncologists. There's some of the quotes I've had over the years from colleagues when I've been talking about gene mutations and precision oncology. Those who are familiar with the Life of Brian film, what have the Romans ever done for us? This P53 stuff is all a total load of rubbish, isn't it? Said to me by a very eminent breast oncologist in the in the late 90s, early 20s. Would genetics testing be helpful? No, never. Not interested, mate. Why are you doing that? So there's a certain amount of skepticism still, and it's taking a while to be overcome, but we're moving in the right direction. A gene is a sequence of DNA that encodes a protein, e.g. the TP53 gene, to go back to that, encodes P53. AKT1 encodes the AKT protein. So a gene, name, and an encoded protein. There's about 20,000 human genes. I checked it this morning. And estimates up to 100,000 different proteins encoded by those 20,000 genes. So there's quite a lot of stuff to get through to find exploitable, targetable, or usable, clinically helpful genes. There's 20,000, so that's a big workload. Nonetheless, I think it's becoming clear that genomics is an absolutely intrinsic part now to optimize clinical outcomes. And two types, of course, there's germline and there's somatic. Which one is more important? Answer is both. In early breast cancer, germline analysis, molecular risk stratification with platforms like Oncotype DX, molecular minimal residual disease analysis, ctDNA, in the metastatic setting, detection, diagnosis, precision, personalized treatment solutions from tissue and circulating tumor DNA, and response evaluation. Now, I was going to talk about loads of case studies from our practice with ctDNA, but I know we've got Isaac coming later, so I'm going to talk about something else. I'm going to start with germline. Identify germline mutations that predispose individuals to cancer using normal tissues, such as normal blood cells or the cells that are in saliva, and next generation sequencing with panels of genes. And this is now absolutely routine. Loads of companies provide it. It's not very expensive. Why do it? Well, increasingly importantly, to inform management. I'll show you some data in a minute that illustrates the importance of identifying loss of function or deleterious pathogenic mutations in some breast cancer susceptibility genes, because they inform the use of PARP inhibitors, poly-ADP ribose polymerase inhibitors, such as olaparib in the adjuvant setting. And from the surgical perspective, understanding the germline or hereditary basis is really important in telling us what to do to risk reduce, for example, the contralateral breast and the ovaries in many cases. And of course, we mustn't forget that germline analysis helps to inform and determine the risk to siblings and offspring. Here's a sort of, I've scribbled down a few of the genes that get tested in most of the panels. So ataxia telangiectasia, RAD51C, BRCA1, BRCA2, CHEK2, PALB2, and these are the HBOC, or human breast and ovarian cancer syndrome genes, the high penetrance genes in which germline mutations confer a significant risk of development of breast and or ovarian cancer in a patient's lifetime. And we used to test, when I started, just BRCA1 and 2, but those panels have expanded now. And this would be a typical sort of 12 gene panel would include these genes. Is this adequate? The answer is no, it's not adequate. Why? Because, just an example here, I'm sure all of you will have heard of Cowden's disease. It's a familial breast cancer syndrome, originally reported in the Cowden family. And it was thought for a long time that the gene P10 was the cause of Cowden's disease, which it is in the majority of patients. But 13.5% of patients with bona fide Cowden's disease or Cowden-like syndrome don't have mutations in germline mutations in P10, but instead have them in the succinate dehydrogenase B gene, SDHB. And critically, in these individuals with a P10 mutation associated or non-P10, which have SDHB mutations, there's a strong enrichment for female breast cancer, thyroid cancer, and renal cell carcinoma, the commonest type of kidney cancer. So it's really, really important that, for example, SDHB should be in all germline panels. Cowden's disease, breast cancer, colon cancer, lipomas, renal cell carcinoma, thyroid cancer, endometrial cancer. And if the Cowden's disease patient sitting in front of you does not have a P10 mutation, but has a clear clinical Cowden-like syndrome, you must test them for SDHB, succinate dehydrogenase B, because mutations, Cowden's disease families with SDHB-associated disease, there's a strong enrichment for breast cancer in those patients. How does germline genetic analysis inform anti-cancer therapy? This is an increasingly strong reason for doing it, because if you have a germline mutation in BRCA1 or BRCA2, you can exploit this therapeutic strategy called synthetic lethality using the PARP inhibitors. Now, we don't have enough time to go into the science of it, but suffice to say that, exactly as I just mentioned, a germline loss of function or deleterious mutation in BRCA1 or BRCA2 confers sensitivity to the PARP inhibitors. This was initially thought only to pertain to BRCA1 and BRCA2. Now it's clear that a third gene, PALB2, a common cause of HBOC, also confers sensitivity to PARP inhibition. This was shown in the initially the importance of this shown in the Olympiad study. This is for metastatic breast cancer arising in the context of a deleterious mutation in BRCA1 or 2. Patients will have previously received chemotherapy with anthracycline and taxane. To go into the study, they must have had 2 or less prior chemotherapy lines of treatment, or if they were ER positive, to have progressed on 1 or more endocrine therapy. Those weren't allowed. Bottom line, short story, cut the story short, the trial was randomized to have olaparib or chemotherapy of physician's choice, the dreaded TPC, and time-dependent clinical outputs outcomes were monitored. Here's the Kaplan-Meier. The green line is patients treated with olaparib. The orange line is patients with physician's choice. And you can see there's a statistically significantly better clinical outcome measured in progression-free survival with the PARP inhibitor, olaparib, first-generation PARP inhibitor, than with physician's choice chemotherapy. This is by independent radiological review. The Embaraka study used a next-generation PARP inhibitor, talazoparib, and showed exactly the same thing, that PARP inhibitor in patients with germline BRCA and 1 or 2 mutations was the treatment of choice in that setting. And following the Olympiad, the PARP inhibitors were evaluated in the adjuvant setting, post-early stage breast cancer, surgical and chemotherapeutic treatment. In this, patients were required to have a germline BRCA1 or BRCA2 mutation, to have either triple negative or high-risk estrogen receptor positive disease, and to have completed at least 6 cycles of chemotherapy in the adjuvant setting. And the two arms were 12 months of olaparib or 12 months of placebo. And this is the randomization protocol study design. And these are the take-homes. Adjuvant olaparib versus placebo conferred a substantial improvement in overall survival at 4-year follow-up. The specific numbers, 83% were invasive disease-free survival, 87 versus 79 in favor of olaparib for that. Adjuvant olaparib, therefore, is the treatment of choice in germline patients with germline BRCA1 or BRCA2, including those with ER-positive disease, and comes with the caveat of the risk of myelodysplasia. It's very small, and in this study, with 1 year of olaparib, there was no increase compared with placebo. So, knowledge of germline status of specific genes informs optimal systemic therapy in both metastatic and adjuvant settings and improves clinical outcomes. Hypothesis, statement for discussion: it should be mandatory for all patients. Why not? Why is it very restricted in certain situations? It shouldn't be. Other genes are important too. PALB2 I briefly mentioned. There's a 4th gene called SF3B1, which is rarely germline, but frequently somatically mutated, that confers a BRCA-like phenotype and sensitivity to PARP inhibition. So you can see that this is just scratching the surface. This is early days, but really very important. And I am a firm believer that germline testing should be mandatory for all patients. Here's a little case study just to illustrate. This is a patient from my own practice, 44-year-old lady, family history of renal cancer. She had a tiny little 5 mm grade 2 invasive mucinous carcinoma with more extensive intermediate grade DCIS. She was treated, therefore, with left mastectomy and negative sentinel lymph node biopsy, and the receptor expression phenotype ER8, PGR8, HER2 negative. Postoperatively, she had radiotherapy and she's on adjuvant endocrine therapy, but a germline showed up 2 fascinating mutations in succinate dehydrogenase B. This is a pathogenic variant, whereas the Fanconi M variant is a VUS, variant of uncertain significance. Nonetheless, this patient needs she needs a tailored, personalized follow-up. She needs to have a discussion about contralateral breast, the ovaries. She needs to be monitored for renal cancer. Now you can see that simple blood test really changes everything for her, which I've summarized there. That's germline. That's a lightning fast, superficial skate through germline. Now I left this in. This was the original slide that I was going to put when I was going to chit chat about ctDNA, but we've got that coming from a real expert. So only I'm going to say, why do patients die of metastatic disease? Metastasis happens, patients die because of metastasis. Why does metastasis happen? It's either de novo, when you can't stop it, or you've got disease recurrence because treatment for early breast cancer does not kill all the cells present. So that was I wanted to reiterate that as a sort of precursor to our talk we're going to have in a minute on ctDNA. But breast cancer is a heterogeneous disease with different molecular subtypes. We heard that in our first talk. Precision medicine methods are based on the selection of a suitable biomarker to inform the effectiveness of targeted therapy. Minimize off-target toxicities, maximize benefits. Simple. There's multiple druggable mutations in breast cancer patients now. Improvements in technology have made this simple to do, either from tissue or from blood, liquid biopsy. What are these actionable mutations? I've just put a few of them down here. So you can, as I say, you can find them in blood from a liquid biopsy, or the preferred option in some ways is tissue, because you can do PD-L1 on that. You can check for change in HER2 status, as we heard. Liquid biopsies analysis of circulating tumor DNA, circulating free DNA. So the genes that have got oncologists excited: ESR1, PIK3CA, PTEN, AKT1, ERB2, ERB3, SF3B1, just gene names. ESR1 is very popular at the moment. This is the gene that encodes the estrogen receptor. And you very rarely find mutations in ESR1 in a primary breast tumor. When a patient's been on letrozole or an aromatase inhibitor for a while, you see a massive increase in activating mutations in ESR1, which constitutively activate the receptor, so it fires in the absence of estrogen, and informs the use of the SERDs, the selective estrogen receptor degraders. Estrogen receptor alpha, which is the one we're interested in, 5 amino acids encoded by ESR1, the wild type receptor, which is present in breast cancers, ER-positive breast cancers at diagnosis, is ligand activated. The ligand's estrogen in blood. ESR1 gain of function mutations, approximately 60% of metastatic cancers progressing on endocrine therapy. Over 50 different mutations described. Very low frequency in primary tumors because no selective pressure. Main selective pressure for mutation is treatment with aromatase inhibitors, which reduce body estrogen to nothing. There's a little cartoon of the ESR1. You can see where the mutations cluster. That's in the ligand binding domain where estrogen binds. You get this, anyone who's done as many liquid biopsy or tissue biopsy tests as I have will know all the old favorites: Y537 changes, D538, E380. You see, these are by far the most common ones, and quite exciting because we have some new drugs to target them with. And most importantly, these graphs show that ESR1 mutations appear late in metastatic cancer. They're very low in primary tumors. The graph on the right shows us they're a little bit more common in early metastatic breast cancer. They're vastly more common in late metastatic breast cancer when patients have been on aromatase inhibitors. This is a Kaplan-Meier showing progression-free survival in patients. This is from the Emerald study on which I was a PI. This was testing elacestrant, which is a orally bioavailable SERD, selective estrogen receptor degrader. And these are patients with ESR1 mutations, either treated with standard of care or receiving elacestrant. And you can see clearly with the blue curve here that treatment with elacestrant is markedly superior. And there's a set of patients who get sustained response. Elacestrant was licensed about 5 months ago in the UK. You have to have an ESR1 mutation to have it, and so you have to do some genomics. You have to do some genetic analysis, otherwise you can't use elacestrant. PIK3CA, PI3 kinase C alpha, common cause of resistance to endocrine therapy. And we have a first-generation PIK3CA inhibitor called alpelisib, which is used with Faslodex, according to the BYLieve study, is a very effective drug, although toxic. Mutation in PIK3CA activates mTOR and informs the use of the mTOR inhibitor everolimus with Faslodex. And new and exciting, if you have one of these three mutations detected either by tissue genomics or by liquid biopsy, P10 again, our old friend P10, inactivation of that or activation of AKT1, remember that's the gene that encodes AKT, or PIK3CA, that activates the AKT signaling pathway and confers sensitivity to the new drug capivasertib, as in the Capitello 291 study. So if you find any one of those mutations in a patient who's previously had a CDK4/6 inhibitor, you can now use capivasertib, which is an effective, well-tolerated AKT inhibitor. Those are the main ones. There's more coming. ERBB2, this is the gene that encodes HER2. And we heard a lot about HER2. HER2 low is very trendy at the moment and incredibly useful with the advent and the availability of trastuzumab deruxtecan, activating mutations in HER2. So you don't just, if you don't have overexpression or amplification, you can have activating gene mutations. Probably 5 to 8% of my endocrine therapy resistant patients have ERBB2 mutations. We've got a catalogue now of about 20. And you can drug that. You can drug with neratinib. You can even drug with trastuzumab deruxtecan. But very important to pick those mutations up. And finally, SF3B1, remember, I briefly referred to it. Very interesting, exciting, that if you have loss of function mutation in SF3B1, which occurs in loads of cancer types, strongly, frequently, commonly in metastatic breast cancer, particularly at amino acid 700, this confers a BRCA-like phenotype and sensitivity to PARP inhibitors. So we're going to see an explosion of olaparib use or next generation PARP inhibitors far more commonly than just with germline mutations in BRCA1, BRCA2, PALB2. SF3B, a somatic mutation, also confers sensitivity to PARP inhibition. So these are just examples. These are emergent. There's loads of others, but an illustration of this exciting field of genomics informed management. That's what I'll end on.
That's great. Thank you, Tim, for that. And you can see the number of new medication that are coming on the market for all those new things. And that's why us surgeons are getting more and more confused. That's great to have that lovely update. Now, the next speaker will be introduced by Peter. Peter.
Thanks very much, Yazan, and it gives me great pleasure, and it's an honor to introduce Isaac Garcia Murias. I've known him for over 10 years now, and he's been the lead scientist in the molecular oncology lab in the Institute of Cancer Research, which is the sister institute to the Royal Marsden in London. And he's a very highly published and cited scientist who's done much of the translational work in ctDNA standards of analysis and clinical implementations. And not just in breast cancer, he really led the way for breast cancer, but now is a massive advisor for all other cancer types as well. So without further ado, Isaac will hopefully hear about how we're going to move to implementing ctDNA technology clinically in breast cancer management. Thanks, Isaac.
Thanks for the presentation, Peter. It's a pleasure to be here. Thanks for the invite. I'm just going to try to share my screen and see if this is going to work. So let's share that. Let me get this into full screen mode and swap my screens because I have multiple. Okay, so here we are. As I said, it's a pleasure to be here. I'm going to talk to you very briefly today about how we are going to use circulating tumor DNA in the clinic. How can we implement circulating tumor DNA in the clinic, specifically in breast cancer? So let me see if I can stop this from moving. There we are. So what is circulating tumor DNA? Very briefly. Circulating tumor DNA is that fraction of DNA that comes from tumors and you find in what we call liquid biopsies. So there is currently liquid biopsy is a synonym for blood. I mean, there's multiple biofluids in which you can find circulating tumor DNA, but we normally use blood because it's easy to obtain. Now, there's two things that you need to remember about circulating tumor DNA. Number one, is very fragmented. These are very, very small fragments of DNA coming from the tumor. And number two is very diluted. And by very diluted, I mean most of the DNA that you find in circulation comes from healthy cells that die, so apoptotic necrotic events, and these mask the signal that comes from your ctDNA. So in the field, we tend to talk about cfDNA to refer to all the DNA that you find in circulation from healthy and from tumor. We just refer to that later fraction as circulating tumor DNA. Now, another interesting thing to note is that we know that the presence of circulating tumor DNA is prognostic of outcome. The more circulating tumor DNA you have, the worse you're going to do. How do we analyze circulating tumor DNA? So we use genomics. I mean, Tim just gave us a fantastic talk about the use of genomics, both in solid and in liquid. And we use these approaches when we test for circulating tumor DNA. Now, we basically divide these into two approaches, what we call tumor-informed approaches and tumor-agnostic approaches. So the tumor-informed approaches require that you sequence the tumor to identify mutations mostly in order to design panels for circulating tumor DNA. Currently, we use whole exome sequencing, but we are moving towards whole genome sequencing in order to identify a larger number of mutations and be able to increase the sensitivity of these assays. Now, when it comes to ctDNA, we use either personalized assays to identify the presence of these mutations, mostly in early breast cancer, or we use defined panels in metastatic breast cancer, depending on what we want to interrogate. And virtually, all the data that we have generated at the moment is with this type of tumor-informed assays. Now, the future, I think, is very exciting because it offers the possibility of utilizing tumor-agnostic assays. So these are assays that do not require knowledge of your tumor genomics previously. So you can bypass the sequencing of your tumor, and that is going to streamline the workflow of your analysis. You don't need to get the tumors into the lab, and normally it takes a bit of time to get them from the pathology departments and so on. You don't need to put sequencing approaches on top of that. Now, what we are trying to identify here are specific methylation patterns that are associated with circulating tumor DNA, or we are looking at the fragments, so the fragment size of this circulating tumor DNA, or at the nucleosome position. So these are the positions of the nucleosomes take on the DNA, and they are markers of the transcription and activation of those genes. Now, logistically, as I say, they might be easier to do. Number one, because you don't require tumor. And number two, because a single assay could be used for all the patients. So you bypass these personalized assays. Now, we don't yet know if they offer the same characteristics as the tumor-informed assays. And we don't know either if they are going to be more expensive than the tumor-informed assays. If that's the case, repeated monitoring might be pretty expensive. But this is something that is coming down. You know, this is something that is in the pipeline. We're working hard to move from informed to agnostics. And I think potentially in the future, we're going to have an interplay between the two approaches, depending on the indication. So where can you use circulating tumor DNA as a clinical biomarker in cancer in general, but for this specific webinar in breast cancer? So it can be used all across the disease, from early cancer detection. So these are people that don't have disease yet. They might have family risk. They might be high-risk patients. all the way into the early setting to detect molecular residual disease or to survey recurrence, and well into the advanced and the metastatic setting, where we mostly use it to stratify patients to treatment or to monitor response to treatments. For the purpose of today, we're going to focus mostly on the early setting and the advanced setting, and we're not going to talk about the early cancer detection. So let's start with the early setting, molecular residual disease and recurrence, surveillance of recurrence. We know that if you detect circulating tumor DNA in this diagnostic pre-treatment sample, you have a prognostic marker. So those patients that have ctDNA detected pre-neoadjuvant chemotherapy do worse than those patients that are ctDNA negative at this time point. And several studies have shown this. Now, we know that this circulating tumor DNA detection at baseline or the diagnostic sample is associated with high-risk features. But what we don't know yet is if it's an independent risk factor or if this is going to be associated with other risk factors like tumor size, for example, or subtype. What we think is it has the potential to aid the prognostication of these patients and to guide therapy, especially in this neoadjuvant setting. We also know that you can use circulating tumor DNA to monitor response to neoadjuvant chemotherapy. And this is data from a couple of trials, the I-SPY 2 trial and the Project trial, which is only triple negatives. In the graph to the far left, you can actually see that you are able now to identify which patients are going to do bad based on the presence or the failure to clear circulating tumor DNA after 3 cycles of treatment. So those patients that are negative at T0 or at the start of neoadjuvant chemotherapy do better than those patients that clear circulating tumor DNA along neoadjuvant treatment. And these patients, these 2 groups of patients, do much better than those patients that fail to clear circulating tumor DNA after the course of neoadjuvant chemotherapy. Now, this allows you to start defining what we will call dynamic monitoring to identify how patients respond to initial treatment. So if they are responding to these initial treatments, they should clear circulating tumor DNA and they should do better. If they're not responding, they're not able to clear the circulating tumor DNA and they tend to do worse. And this also allows you to start combining the presence of circulating tumor DNA with more established biomarkers. Graph in the middle, that's the combination of circulating tumor DNA detection with pathological complete response. And you can actually see that those patients that do not achieve pathological complete response and have circulating tumor DNA do much worse than those patients that have either achieved pathological complete response and are circulating tumor DNA negative, or have not achieved pathological complete response and are circulating tumor DNA negative. And on the graph to the right, you can also start to see that you can combine this, for example, with residual cancer burden, and you can actually see the same dynamics, high RCB, ctDNA positivity, worse outcome than those patients that have lower RCB scores and have clearance of ctDNA. Now, why is this important? This is important because it allows you to start defining a slightly bit more detailed high risk and low risk of patients by adding this data point, this new data point that is circulating tumor DNA. And that allows you for the potential for escalation or de-escalation intervention in breast cancer patients. And by that, I mean those patients that, for example, achieve pathological complete response after neoadjuvant chemotherapy, they don't have circulating tumor DNA. Are they ready to have de-escalation in the treatment. And conversely, those patients that have circulating tumor DNA presence after neoadjuvant chemotherapy and don't achieve pathological complete response could be thought of as patients or high-risk patients that might benefit from escalation of therapy. Now, in the early setting, potentially the most interesting bit that we have seen is the ability of circulating tumor DNA to detect molecular relapse. And we do this by serially analyzing plasma samples along the adjuvant setting. Now, with the new current generation of exome-powered MRD assays, and these are assays that are based on whole exome sequencing of your tumor, we see a lead time from what we call molecular relapse, which is the first identification of circulating tumor DNA, to clinical relapse between 8.9 months to 11.7 months. So close to a year before these patients relapse clinically, you are able to detect circulating tumor DNA. And this is highly prognostic. This is 4 different studies using 4 different approaches, using a couple of mutations by digital PCR, or using 16, 48, or 50 mutations using NGS approaches. And all of them saw the same. They saw that those patients that have circulating tumor DNA detected along the adjuvant setting tend to have a worse outcome than those patients that don't have circulating tumor DNA detected in the adjuvant setting. Now, these assays offer enough sensitivity to detect this, but you can actually see these little steps in most of these graphs to the left. And these are patients that are going to relapse without detection of circulating tumor DNA. That's the reason we are starting to work with much more highly sensitive assays that are based on whole genome sequencing, which allows you to identify a much larger number of mutations and define much larger panels. In this case, up to 1,800 mutations per panel. And then you can actually see here that you have a much higher sensitivity in detecting those patients that are going to relapse based on the presence of ctDNA versus those patients that don't have circulating tumor DNA and do not relapse. Another interesting finding from this is the ability to start to design in prospective clinical trials of molecular residual disease in breast cancer. And you can actually see quite a comprehensive list of the trials that are being run at the moment in early breast cancer, if they are interventional or they are observational, and the type of ctDNA assay that is used. I mean, we have a multitude of ctDNA assays in the market at the moment. It's a pretty hot area. Now, most of these trials haven't reported yet, and we expect that some of these trials will start reporting in the next year to a couple of years. The only one that has reported so far is cTRAC-TN. And it was a bit disappointing, mostly because of the assay that was used. I think it lacked the required sensitivity. But we are very eager in learning a bit more about the new generation of ctDNA assays in prospective trials. What else can you do with circulating tumor DNA in the early setting? So you can actually use it to track breast cancer evolution from diagnosis to relapse. And these are the first time a patient relapses. By analyzing circulating tumor DNA, you are able to start defining different subtypes of, for example, in this case, triple-negative breast cancer, and how these different cancers evolve across the adjuvant setting. So you're able to identify graph to the left top early polyclonal dissemination, which is pretty common. These are clones that are insensitive to chemo and are likely to be present if relapse occur. To top right, you have clones that might differ in chemotherapy sensitivity. And in these cases, chemotherapy as a bottleneck. So it removes some of these clones and it just promotes the expansion and evolution of a different set of clones. And for example, at the bottom, you can see that some clones are only detected after neoadjuvant chemotherapy, and they dominate molecular residual disease and relapse. So you can now use circulating tumor DNA in a non-invasive way to start defining how breast cancer evolves in the early setting. So what about when we talk about circulating tumor DNA in advanced or metastatic breast cancer patients? In this case, we know that tumor heterogeneity is a driver of resistance. So you have a tumor, you administer an initial therapy, or you administer a therapy and you see an initial response, but you do not remove all those clones. There are clones that are left behind that are resistant to this therapy, and these are the clones that are driving this relapse. Most of the mutations in these clones are either subclonal mutations at very, very low frequency, or are de novo acquired mutations. So the question here is, can circulating tumor DNA analysis be used to infer response or resistance to therapies? There is a great interest, and I think Tim touched on this, in hormone receptor positive breast cancer patients that accumulate mutations on ESR1 and PIK3CA after first-line therapy with hormonal therapy plus CDK4/6 inhibitors. Now, the interest in here is because now we have novel therapeutic approaches for patients that harvest these mutations. And I'm going to use this subgroup of patients as an example of how circulating tumor DNA can be utilized in the metastatic setting. As Tim pointed out, we know that the incidence of ESR1 mutations in endocrine-resistant breast cancer is pretty high, so up as high as 48% in some of the studies, like the Emerald study. But what we see is that patients that have been administered aromatase inhibitors mostly in the adjuvant or in the metastatic setting acquire ESR1 mutations. And this is important. It is important because we now have a novel therapeutic approach for these patients. These are the novel cells, that the estrogen degraders, that we know work better when patients have ESR1 mutations. So the two Kaplan-Meiers to the left are from the Emerald study with elacestrant. At the top is all the patients, intent to treat patients, and at the bottom are patients with ESR1 mutation. As Tim pointed out, you can see a clear difference between the two Kaplan-Meiers, the one at the top and the bottom, and specifically at the bottom on those patients that receive elacestrant versus a standard of care. In the graphs to the right, Serena-2, this is camizestrant, this is another novel cert, and you can actually see the same thing here. So those patients that have ESR1 mutation have better outcomes, respond better to these novel cells than those patients that don't have ESR1 mutations. When it comes to PIK3CA, I mean, we know, again, Tim pointed out, there seems to be a bit of overlap between Tim and my talk today, is that the PIK3CA pathway accumulates mutations. So this is the PIK3CA AKT/mTOR pathway, and it's frequently dysregulated in breast cancer. Now, until very recently, alpelisib was the only drug approved for hormone receptor PIK3CA mutated breast cancer, and this is data coming from the SOLAR-1. But now there is a development of novel PIK3CA inhibitors like inavolisib and MEN1611, which will require the development of tests to detect mutated cancers. And we think potentially ctDNA offers a solution here. Sometimes it's very difficult to have metastatic tissue in order to genotype these patients, and your primary tissue is too far removed from this setting to reflect the true genomics of the cancer, especially after they have been administered different lines of therapy. Now, as I said, this is data from the SOLAR-1.
Can you take me to Lord's cricket ground, please? Thank you. Thank you very much.
This is data from the as I said, this is data from the SOLAR-1 trial in which we found that PIK3CA mutations are predictive of response to PIK3CA inhibitors, PIK3CA alpha inhibitor therapy. So to the left, that's a cohort of PIK3CA mutated cancers, and you can actually see that those patients that receive alpelisib plus fulvestrant done slightly bit better than those patients that just receive fulvestrant plus placebo. And on the right, you can actually see that those patients that don't have PIK3CA mutated cancers, there's not much difference between alpelisib and placebo. So what this has led is to the indication of alpelisib plus fulvestrant for the treatment of postmenopausal ER-positive, HER2-negative, locally advanced or metastatic breast cancer patients with a PIK3CA mutation. Now, another interesting thing that you can do with circulating tumor DNA in the late setting is look at the dynamics. So this is the dynamic change between 2 time points in the treatment regime of your patients. This is data from the PALOMA-3 or using the PALOMA-3 clinical trial samples. This is advanced breast cancer hormone receptor HER2 negative patients, pre and peri postmenopausal, who have progressed on prior endocrine therapy. So in here, patients were randomized 2-to-1 to palbo plus fulvestrant, palbociclib being a CDK4/6 inhibitor, and placebo plus fulvestrant. And what you do in here is you analyze the circulating tumor DNA at day 1 of treatment and the circulating tumor DNA at day 15 of treatment, and then work what we call your ctDNA dynamic ratio. And by looking at how the circulating tumor DNA changes between the initiation of therapy and alone therapy, you're able to start differentiating which patients are going to do worse based on their inability to clear circulating tumor DNA. Now, this is data on how patients respond to targeted therapies and how we assess this by circulating tumor DNA detection. This is data from the PlasmaMatch trial. This was the first precision medicine trial run in the United Kingdom based on ctDNA. This trial enrolled advanced breast cancer patients with measurable disease who had progressed on prior therapy for advanced breast cancer or had relapsed within 12 months of adjuvant chemotherapy. What we did here was to test circulating tumor DNA, either with digital PCR or using an NGS approach, identification of actionable mutations, consent, and then stratify these patients to different treatment regimes based on the presence of or absence of a mutation. So if patients had an ESR1 mutation, they were stratified to extend dose fulvestrant. If they had a HER2 mutation, they were given neratinib plus fulvestrant if they were hormone receptor positive. If they had an AKT mutation and they were hormone receptor positive, they were stratified to capi plus fulvestrant. And we also had the basket arm for patients with an AKT mutation that were hormone receptor negative or had a PTEN mutation, and these patients received capivasertib. And we added subsequential arms to the study. So cohort E was for triple-negative breast cancer patients with no mutations, and these patients received olaparib and CT-6738. And remember, all of this is based on genotyping of your circulating tumor DNA. Now, so how do these patients respond to therapy based on ctDNA assessment? So these are 2 examples. To the left, this is cohort B. These are patients that have a HER2 mutation identified in circulating tumor DNA and receive neratinib plus fulvestrant. And you can actually see that in this subset of patients, you have a confirmed response rate of 25%. And to the right, you have cohort C, which are patients with an AKT mutation, and stratified to capivasertib, which is an AKT inhibitor, plus fulvestrant. And in this cohort of patients, your CRR is 22%. Now, what we can see here is that mutations in ctDNA predict response to targeted therapy. That was not the case on cohort E. Remember, these are the triple-negative breast cancer patients with no mutations. In the cohort A to D, we saw that the median CDR was highly predictive, but that was not the case for this subset of patients. And we think that is because ctDNA assessment might differ between different therapies with different mechanisms of action. And the implementation of ctDNA dynamics in this case into clinical trials and practice might require distinct analysis for different therapies. And let me finish with what I think what will be required to implement ctDNA into clinical practice. We've done a lot of work in development and validation of the assays, so ensuring there is analytical validity, clinical validity, and we are trying to demonstrate now clinical utility with prospective trials. But we also need regulatory approval, incorporation into guidelines, and reimbursement. And finally, we also need to incorporate this into clinical workflows. So invest in laboratory and human resources, train physicians, and create a standard operating procedures for application in different clinical scenarios. So although we have done a lot of headway, there still remains a lot of work to be done before these assays become a clinical reality. And I'm just going to finish there, acknowledging all the patients, all the staff, and all the people that have participated in this work. Thank you.
That's great talk. Thank you for the talk, Isaac. And the next speaker will be introduced by Andreas.
Thank you, Yazan. We have heard exciting things spanning from pathology to genetics, translation, how translational medicine will be integrated into precision oncology. And now we will move to the next speaker, who will be talking to us about something which I find very pertinent and very relevant in an era where gene assays have been integrated in our everyday practice. We still lack a kind of consensus. There are widely implemented assays, but not one universally accepted. They are slightly discordant. We need to know how to deal with this. We need to decide how we will optimize that in a workflow that will make things easier for our pathologists and more accurate. And it gives me great pleasure to introduce Johan Hartman, a professor of pathology from Karolinska Institute in Stockholm, a brilliant clinical pathologist and scientist who will give us his own take about the role of AI in this context. Johan, the floor is yours.
Thank you, Andreas, for the kind introduction, and thanks for inviting me. So I understand that we're running a bit late here, so I hope you still have some energies to stay a few minutes. So I would like to today to talk about AI, and because this is an area that goes extremely fast right now. We can see extremely rapid developments. We have seen them especially in the imaging handling specialties, such as in radiology, and now also in pathology when we're going digital. So these are my disclosures. Yes, and this is the hospital I'm working at, the Karolinska University Hospital in Stockholm, Sweden, and the Karolinska Institute, which is the university side of the hospital. We are running together within our two hospitals, the largest breast center in Scandinavia. So as you also heard from Dr. Shaban earlier, we have some biomarkers that, as you all are aware of, they are differing a little bit depending on the countries, but mainly these are the predictive tools that we have been using for many years, but also in terms of prognosis. So we have the estrogen receptor, we have the HER2 in Sweden and many other countries, but not in Britain. We are using Ki67 as a proliferation associate marker in routine pathology. We also have the tumor grade, which is, of course, if it's assessed in appropriate way by an expert pathologist, it gives you very strong prognostic information about that specific patient. But we do have problems here with our current biomarkers. What we can see here is this is just a few examples of it, and this is based on the Swedish quality registers. We actually report all the patients in terms of surgery, pathology, and outcome to the Swedish register. What we can see here is that there is a significant, quite dramatic difference in biomarker interpretations and grade across the Swedish pathology labs and hospitals. And this means that for HER2 levels could be between 5% and 25%. And this, of course, have implications on the way how we treat our patients. And I don't think, to be honest, that the Swedish pathologists are so bad, but I do think that this is a similar scenario we'll find in all countries, that we do have a problem when we as pathologists are performing some of these manual tasks that could actually now be supported by image analysis. So going back to the tumor grade, one of the strongest prognostic factors that we have in early breast cancer, if it's assessed appropriately. However, we do have a problem here that about 60% at least in the ER-positive HER2-negative subgroup actually are within the grade 2 cancers. And the grade 2 cancers is actually intermediate category that are of very, very limited clinical value, as you know. We also know in terms of biology that this subgroup or this group 2 doesn't really exist. It is about half of the patients. This was a study based on old microwave technology from Professor Jonas Berg and colleagues, showing then, as you can see, that there's a clear pattern here that discriminates about 1/3 of the grade 2s that are more like the grade 3 cancers, about 2/3 more like the grade 1 cancers in terms of gene expression profile. So it appears here that there's actually a possibility here of looking at breast cancers high and low grades. And this was also shown now in outcome that the high risk part of the grade 2s actually have an outcome very similar to the grade 3s, and the low risk proportion of the grade 2s have an outcome very similar to grade 1s. So what about digital pathology then, and what can we do about this? So we are now going through a digital shift in pathology. This differs a little bit country by country. In Sweden, we have 31 pathology labs. All are now digital, which means that they are fully working digital in front of the computer screen instead of the microscope. In US, we can see that this goes not as fast. About 5% of the labs are digital, and I would say that Britain is somewhere in between here, but the digitization is going very fast. There's difference here compared to radiology. In radiology, you can get the digital images out. You produce digital images. You don't do that in pathology. You have to go through all the manual steps in preparation and digitization of your slides. But this has a great value for the pathologist, not at least that you can have easy access to your colleagues, to expert colleagues, to talk about problematic cases. We also now have the possibility of using digital image analysis, and that can actually make faster diagnosis, and that can improve biomarker assessments in pathology, and it can also reduce the errors. So there are several examples now of regulatory approved products here in this space, such as measurements of Ki67, estrogen receptor status, and HER2. And I think this will be even more important now when we are looking at biomarkers and very, very, very subtle differences in staining patterns, such as the HER2 low category. Here, image analysis can actually make us to produce much, much more accurate assessments of the cases. But it also has the possibility of going beyond that. And I think, because going digital in pathology is quite an expensive task. We know that we have to go this way, but we also need to have a return of investment. And here now, with the advent of new technologies in pathology, new kind of hardware, compute, but also in terms of algorithms, not at least that foundation models and other modern forms of deep learning technologies, we now will have the capacity to use more sophisticated methods here. This means that from your images, and these are, as you can see here, H&E, the basic staining of all tumor slides or all slides that we do in pathology globally, comprises huge amount of information. This information is also now a consequence of what we have in the genomic area, of course. So this provides much, much deeper information compared to radiology. Now, with the novel technologies in AI, we can actually extract prognostic and also predictive information out of these images. And these are, of course, tasks that I cannot perform as a trained pathologist. And we have seen now quite groundbreaking results during the last years. So this is actually an area that goes very, very fast. We can see everything from prostate cancer, colorectal cancer, to new developments in breast cancer in this space. based on mostly these H&E stain slides, the basic stain slides, to retrieve information. Also then trained on very large data sets. So to do this, you need very large data sets. This is an example from our lab where we actually showed, and there are several other authors have shown that you can actually predict the estrogen receptor status, the Ki67 as well as HER2 directly from your H&E stain slides. And there's several other papers in this space now that predicts the biomarkers directly of the H&E slides. I think this is an extremely exciting future, showing that perhaps in the end, we won't see the same kind of predictive biomarkers as we're used to as pathologists based on immunohistochemistry. Perhaps these will be as good, even better, but based directly on your H&E stain slides. We can also see that it predict the difference in heterogeneity here. What we have done here with deep learning in the images actually gives you prognostic information. So, and that is quite clear for us pathologists that the very heterogeneous tumor has actually a poor outcome. Here, what we did was they actually predicted the patterns associated with PAM50 genes in the gene expression profiling. What about risk of recurrence then? Yes, we know, of course, and that you have heard in the talks here, that patients with high-risk tumors, they are often recommended systemic chemotherapy. Here we have several important clinical risk factors. But we also know that this is especially important for the ER-positive, HER2-negative subgroups, whereas the triple-negatives and the HER2-positive most often have specific recommendation according to the guidelines. So a problem here again is that about 50% of all breast cancers are of an intermediate risk group category, where we are not really sure about the risk of recurrence. And this, of course, gives us a high risk of over or under treatment of the patients. We have several gene expression profiling tests. I call them genomic tests here. So this is actually my focus here is on transcriptomics, not on genomics. Here we have one as Oncotype DX, perhaps the most famous one, but we also have the Prosigna test and MammaPrint. All of these are done on FFP, the formalin fixed material, which means that you need to section the tumor again. This takes time and need resources from the pathology labs. Sometimes you even have to send the samples away to other countries. So, although these tests have a lot of evidence, some of them, they are quite problematic in the way that they are having high costs, they require demanding logistics, and they're not accessible to most of the patients on a global level. They might be accessible in Sweden and Britain, etc., for many patients, but not for the majority of patients. So we set out with a question, could we actually perform a risk stratification based on the H&E stain slides? This is a paper that you can read in Annals of Oncology. We published it some time ago. What we actually did here was that we built a very large data set of H&E stain slides coupled to longitudinal data, so the outcome. We also know the grade of the patients. An ensemble of AI models was then trained to identify the high-risk cancers and the low-risk cancers, the grade 1 cancers. This information or this ensemble of AI could then be used to stratify the grade 2 cancers into a high and a low risk category, as I showed earlier on gene expression level, but of course now much faster. We also could see then that by stratifying these cancers, the grade 2, we could see that the high risk group of those had an outcome similar to the grade 3 versus the low risk had an outcome very similar to grade 1 cancers. So based on AI image analysis, we could get rid of this intermediate category and get a high risk and a low risk group. And this is I think the most important subgroup here. The grade 2 cancers, often the ones that don't have a high Ki67, they don't have a low Ki67. They are in the middle, so to say. A gray area within breast cancer, where we actually need to identify the ones with a high risk of relapse and the ones with a low risk of relapse. We could see also in this analysis that the AI analysis was an independent prognostic factors with the same kind of prognostic strength as lymph node metastasis. So this was an analysis that I cannot perform as a pathologist. It was completely based on the H&E stain slides. So going forward, then we would like to also not only use this as a research, we went forward together with the Karolinska Institute and started with the startup company StratiPath that we founded some years ago to develop this all the way to a regulatory approved product that can be launched. And that's now been launched at several hospitals in Sweden. So we're running it now both in clinical studies and also in routine cancer diagnostics in Sweden. This gives you this, I'll just give you a brief introduction to it, what it is. So it's the first in the global, first regulatory approved product in this space. Although I think that very soon we will see additional products. It gives you prognostic information directly out of the images. So it categorizes the cancers into high and low risk, and gives you also some more granularity in the reports in terms of a risk score. And it performs this assessment, which is a cloud-based analysis, which means that you don't need to be fully digital. It's enough to upload one H&E stain slide from your lab. So a simple tabletop scanner is enough. This gives you then a risk stratification in less than 30 minutes compared to the gene expression test that takes considerable more time. And importantly, the result is always available to the tumor board. Then you can decide as a clinician if you want to go forward with some cases for gene expression profiling test as well. So in this way, it's a decision support tool. It does not replace the pathologists. I do think we will need a pathologist as myself for many years to come, but we do see problems in terms of the variability and the accessibility to prognostic profiling. So this is, I hope is a way forward also to give access also in low resource setting for prognostic profiling of the breast cancer. And you get the same kind of profiling, respectively if you're an expert pathologist or not. And this way as a more cost-effective alternative to the molecular assays. And this is now also approved for the British market. So the current version now is approved for a resected specimen. We have ongoing studies now also on preoperative biopsies, and we published that recently. But this is on the resected specimen, then that is done by the pathologist, uploads the images. And this is just very briefly my last slide here, showing also importantly in this space, validations are crucial. We have several of these studies ongoing. This was a publication from last week in Breast Cancer Research, where we actually can show in 2,700 patients that we can see a similar risk prognostication by the AI model, by StratiPath in breast cancer patients. And this is in terms of prognostic performance, progression-free survival. What you can see here are 5 different risk groups based on the AI. So the Group 1 here is more or less the grade 1 cancers, whereas as you can see, the 20% in the top, and the second, Group 4 and 5, has a very high risk of relapse compared to the other ones. So this was an independent prognostic validation. So in summary, we can see that, as all of you know, we have several limitations in breast cancer diagnostics. We have, of course, a deficit in pathologists. I don't think we can be able to assist all of this by AI, but it can definitely support us and give in more high quality reports. We have a limited access to precision diagnostics and gene expression tests for most patients in the world. And I don't believe forward that we can send samples from all countries. That won't work. Here we can make a prognostic analysis of the breast cancers based on AI in a much faster way and also much cheaper compared to the classical old models of gene expression profiling tests. By that, I would like to thank the team behind this, my research group, Matthias Rantalainen's research team, and also StratiPath, which has done the clinical development of the product. Thank you.
Fascinating. That's great. And each time I see an AI talk, I just realize that we're going to change, things will change suddenly in the coming few years. And I think we need a webinar only on AI. I prepared a talk on AI only 3 or 4 months ago. It's already out of date because of the amount of things that are being published. Fascinating 4 talks. Thank you for giving those talks. There's quite a few questions on the Q&A section. So I will just say for Andreas and Peter, is there any opening comments? And by the way, Johan, Ricardo's other half is a pathologist, is I think a cardiac pathologist, and I could see Angelis coming and having a look at the beginning of the presentation and watching most of the slides, which is great also to see people from other specialties also interested in this. Peter and Andreas, any comments, any questions?
But of course.
Let's start with Andreas.
Yeah.
Okay, So great talks. These are all very, very, very stimulating aspects of the work, and especially for those engaged with heavy clinical everyday work, we kind of forget it sometimes. I have a question. just to be able to get some comments and promote the discussion a little bit, primarily for Abir and Johan as pathologists. We are always hunting the pathologist because we want the information, and it's sometimes we think that a specimen is something that you put in a slot and then a paper comes out with an answer, whereas we know that the reality is much more complex. And the holy grail of the last decades were the ER positive, HER2 negative cancers, and how and where to safely de-escalate. And at some point, we thought that the genomic assays will give us this response. They are out there. We are using them in clinical routine. We thought in the beginning that they would replace clinical characteristics. Now, very recently, the new publication by Sparano in New England Journal of Medicine just last week told us that it is not really like that, but if you combine it, it gets even better. And now they are talking about the RS clinical score, and then they will be developing the RS late score. But still, that does not overcome the issues that Johan highlighted. You need extra resources to cut. You need somebody to ship. If you're doing the prosigna, you can do it, but still you need people to do it. Now, Johan suggests something that I think is genius. Making AI do it for you by the material you have already there. How important is this evolution in an era where pathologists do not grow on trees, where you can just pick up a pathologist? And, what are your thoughts on that?
Yeah, so thank you, Andreas. I think very good points here coming. First of all, I would see that it's clearly shown now that the gene expression profiling test has an added value. It cannot replace the pathologist, and it hasn't been even shown so in studies. I think that I don't think the time has come that I still think we will use gene expression profiling tests for more years. I do think that in 10 years' time, we will not use any more gene expression profiling tests. This is an old technology in the way we see it today. I think it will be completely replaced by other technologies. But I do think it has a place right now and during the coming years. I think it's important that we, emphasize here that there are novel technologies coming in, not only in this space, but also in terms of in genomics, ctDNA, etc., that I think have definitely an added value now. We have a deficit of pathologists nearly everywhere, so definitely this kind of technologies that can increase the quality, precision of our work. I think that is highly, we haven't talked today about, but there's also now the possibility of finding cancers in the images that can also, work in a safeguard our assessments. And I think that's also a very interesting area.
Yeah, I fully agree, and I enjoyed Johan's talk. Fantastic. I think we can get away from the issue of like the shortage of pathologists, and not only pathologists, the lab staff as well, because before we can do digital and AI, we have to still go through all the process of lab processing, getting the slides. We're not like radiology. Radiology could avoid getting the old film and just look digital. We still have to produce a glass slide, digitize it, and then apply AIs. I agree. I think AIs have a lot of potential. We talked today about Ki67, for example. And if you apply the strict criteria of the Ki67 working group, pathologists will be there looking at a slide to assess it properly for about half an hour to count. But if we can put that in a machine with an algorithm to do it quickly for us, again, AI cannot be used independently. I think it's really important that there is an oversight of pathologists, because if you put a digitized slide in a machine, it will give you a reading, regardless whether it is correct or not. We need to make sure that it's picking the right area. Are we looking at the cancer, at the stroma, TILs? And this can only be done by double checking with the pathologist. So I don't think we can just let it do the work itself. There has to be this oversight.
No, my point is that how you reduce the groundwork, the footwork that you would need to do with with what is currently standard of practice. I'm just thinking, I will mention it because I know that most of the audience are surgeons and it will be easier to correlate. So some years ago, a randomized trial was published in New England Journal of Medicine that said that if you take routine margin shavers of the cavity, you get less re-excisions. And this is a nightmare. I mean, our own pathologist, and I think that we have had this discussion in private with Johan, is that the shaver takes as much time as the main specimen. So you give them a specimen and then you give them 4 to 6 extra bites. And this is something that adds to complexity with not really clinically relevant value always, isn't it? That's why I think that this is important.
And Peter, any comments from your side?
Look, I agree with everything that's been said, and I think sadly we see less pathology slides in our MDTs as they become busier. But I think at least it gives us an appreciation for the huge heterogeneity. I've got two questions actually. One for Johan. Do you think that we need to look at full tumor, or what they call sort of large slide analysis for AI, so that we see the whole tumors rather than small sections? That's my first thing. That'll really change practice, because we just don't have the sort of throughput at the moment to do that. Do you think we need to look at sort of increasing the scale of what we look at?
No, I don't think so. I mean,
Okay.
I think the current version, as I showed you now, it's approved for whole sections. I do think that we had a publication some month ago that we can also do a similar thing on preoperative biopsies, although it's not regulatory approved yet. So I do think that we can do a lot. But also, I mean, in pathology, as we all know, I mean, the size matters, so to say. I mean, if you have a larger image, of course, it gives you more information. If the tumor is very heterogeneous, we know it from biomarkers. I do think, whole section is good to have. But in these we live in a world with a lot of neoadjuvant treatment. We have to go for the biopsy. We have to stick to that. And yeah.
So
okay.
Go on.
So my other question is to Isaac. Isaac, are we seeing the use of AI in terms of the analysis of the sort of the very, as you mentioned, the very low amounts of ctDNA in samples? Do you think we, apart from whole genome sequencing, can we use AI to tease out aspects of those samples to streamline analysis?
Yeah, I mean, I think AI is pretty hot across all the disciplines at the moment. I actually think that AI in terms of ctDNA is going to be useful to, for example, in tumor agnostic approaches, to be able to define the presence of the absence of tumor in ctDNA based on multi-omics. So, it's just not your methylation status, it's just methylation status plus the size of your fragment plus the nucleosomic position plus the dynamics of ctDNA. That is going to be very difficult to be done manually. I think all of this is going to be end up fed into some kind of AI black box that will be trained with the different features in order for this to identify the presence of the absence of tumor and then the different characteristics of that tumor.
May I ask a couple of practical questions, really? Johan and Abir, do you repeat always the receptors after chemotherapy? What's your practice, Johan?
Well, I would say that we do, if we have the possibility. If there's any tumor left, we report. We actually in Sweden we always reassess the biomarkers. We do that, yes.
Yeah, so we have been doing it for years, but actually it's not mandatory in the UK guidelines. So there is a lot of evidence that they do change, and there is a good proportion of cases where you have ER, PR, and HER2 change. PR is the most common, HER2 is the least common, and changes from positive to negative are commoner than negative to positive. It is thought to be, if you don't have the resources, obviously it needs a lot more resources. It's more relevant where you start with a negative result, so ER negative or HER2 negative, because if you get a switch to a positive status, then you can have a new drug that you can use that would otherwise wouldn't have been considered. The other thing as well is that with the emergence of the HER2 low category, that also changed, and there is an evolution between the pre-treatment and post-treatment biopsy. So particularly if the original was negative, consider doing it. But at our end, actually, our oncologists do ask for it, and we do bring the patient back to the MDT to get the final receptor and HER2 status.
Because where I work now in the NHS, we don't repeat them, but in Scotland, in Aberdeen, we used to repeat some of them. And in the private sector, we repeat some of them. And the dilemma will be, for example, HER2 positive disease, post-chemo small residual disease that's HER2 negative. What do you continue with anti-HER2 treatment? Do you continue dual blockade? What do you do? So sometimes it also adds to the decision-making. Unfortunately, we lost Tim. That would have been an ideal question to go to Tim as an oncologist, but I can see Isaac has his hand up. You want to say something, Isaac?
Yeah, I'm just going to be a slightly bit controversial, and I'm going to say that potentially those patients that lose expression are also very interesting. So we're talking about hormone receptor positive patients after neoadjuvant chemotherapy that lose the expression of the estrogen receptor gene. These patients, they're not going to benefit from hormonal therapy. They become triple negatives, So I think it is important just not to assess your receptor status on the primary or in the surgical sample, but I think it'll be really cool to be able to assess receptor status across treatment. Now, the only way to do this is non-invasively, because you're not going to have the new receptor status until this patient relapses. So the ability to say this patient has lost expression of a given receptor and is not going to benefit from this treatment, let's do a switch of treatments, I think is super cool.
But also, Abir and Johan, is it really a change in the receptor, or is it differential response?
Yeah, I think this is a very big question that I don't think we can talk days about this. So there are, of course, true downregulation of receptors and biomarkers, but there are also transient effects by the treatment. So the thing is, what can you actually trust? So I agree here definitely with Dr. Shaban that I think that the preoperative biopsy is the most important. But we have also the question of heterogeneity here. So there might be areas that you haven't biopsied from the beginning that might turn out to be positive or negative in the resected specimen. So this is complicated. Of course, the more the better. I think I would strongly emphasize here. So until we have ctDNA and liquid biopsies as regulatory approved systems for everything, I think we will go that way, is that we take biopsies from the metastatic lesion where we have relapses, because there it's critically of clinical importance if we have changes in biomarker levels.
So, and the other question was also for Abir. You mentioned the PD-L1 expression. It's different in different tissue. So if you have it negative in the liver because it's 13% are positive, and you have positive in the breast, and you have a primary still in the breast, does that mean that they will respond for the immunotherapy in the liver?
Yeah, exactly. So the trial used actually any tissue available, and they treated on any positive result throughout the patient pathway. So if it is positive on the primary or metastatic, as long as you get a positive test, a positive result, then you can give the drug, and it can be any of them. So that's why some authorities recommend testing more than one sample. So if you get it negative and you're still keen to give the drug, test another sample, and if it is positive, then go ahead. The same applies for HER2 low as well. Any sample throughout the patient pathway.
To ask Peter and Andreas, in your practice, if somebody has a liver met and they've had a biopsy and they came it's triple negative, PD-L1 negative, will you still look for other sites to biopsy?
Optimally, yes.
And Peter, is that usual practice for you?
Well, yes. I mean, a lot of the stuff they do, for example, at the Marsden is really ctDNA based now, as you heard with plasma match. So I think that's what needs emphasis, is that when you look at the plasma, it potentially captures the whole genomic landscape of the whole patient, maybe excluding CSF, for example. But maybe Isaac wants to comment further. But the point is, you're not sampling one site; you're potentially sampling all manifest clinically, active sites. And that's the point.
And will ctDNA be the answer to all those things, Isaac?
I don't think so. I think it'll be another data point. There's no single thing that is going to be the answer to everything. I think it's going to be another ledger to add to the information we get out of the tissue. You cannot do IHC out of circulating tumor DNA, but you could potentially in the future do gene expression. We're trying to do gene expression out of circulating tumor DNA at the moment, which will give you a readout of receptor status. And yeah, I agree with Peter. I think one of the advantages of ctDNA is that potentially it captures all the tumor heterogeneity that the tissue misses, because you're only sampling one specific region. Unless you guys do multi-region sampling, you're always going to miss clones, which we think are represented on ctDNA. But, as much work as we have done, still early days.
Even in multi-region sampling, you can actually never come back and say, I'm 100% that I have a representative sample of what I have, because it's a matter of number of lesions, it's a matter of heterogeneity, both in the primary or the relapse or the metastasis. And I agree with what Isaac is saying. I think that the ctDNA will give us some hope and some solutions, and then it will generate more questions, and then we will do like we did with other solid tumors, where after ctDNA we went to discuss tissue microRNA and then circulating microRNA, and small pieces of the puzzle will come into place, and it will be some years until we know how to deal with it. Now, I had a discussion, I had a question for Tim, but he's not here. But I think that given the fact that we're among surgeons, it would be worth mentioning. I have to start by saying that I understand and agree with the statement. I think that we should offer genetic testing to all cancers, especially since we have the drugs that can modify and improve outcomes. The big question is, what do you do with the knowledge of a metastasis that has driven the surgical community in unnecessary extensive surgery? And I would like to ask everybody, let's say that this is a multidisciplinary meeting. So you send somebody there and you get them a PALB2 mutation of a variant of unknown significance. How do you solve, on a clinical perspective, the patient question, and what does this mean? Yazan?
Well, I usually say you treat the cancers first, and then you deal with the gene later most of the time. In very small cohort of patients, you need to deal with them at the same time, especially, I'm starting to do more BRCAs, especially as for some ladies that will, because you'll be denying them some treatments, especially if they go for chemo and neoadjuvant chemotherapy, or if you find that there is some disease elsewhere. So there is no one answer that fits all. And the PALB2 of unknown significance, without a family history, without any genetic guidance, is a it's a big problem.
Yeah, that's an extreme scenario. I had a case at the clinic recently that was, because everything advances, so does this. So Johan will understand the expression. So we call the variants of unknown significance VUS in Swedish, and now we have this svagus, which is the weak VUS, and you get a standard response from the genetical consultation. We don't know what that is. Check with us again in 3 to 5 years, because we may know more things. And now and then you get something that you and the patient don't know what to do with, actually.
If it's unknown significance, we will not do much with it, in all honesty, I think, Andreas. You just need to learn how to ignore it and check it again in 3 to 5 years, as the geneticists say. I don't know what you do, Peter.
Well, I actually think one of the most essential roles of the clinical geneticist is to filter out what we don't understand yet. And I think, we hope not to see on our final reports is a VUS, or if it's there, caveated very carefully, because it just confuses issues massively. And I think it leads to a lot of anxiety on the patient's part as well as the clinician. One of the things I was going to touch upon, actually, following on from what Andreas just mentioned, was that, and Tim has sort of alluded to, was not just germline testing, but looking at the somatic tumor changes, for example, BRCA functionality, because drugs like olaparib and PARP inhibitors may be useful even if a germline variant is not present, but somatically it's present in the tumor and may be at metastatic sites. So I think that's another, huge area to explore, and really hasn't been fully done yet.
And then that will be a discussion with oncology and geneticists, because it will be a very complex thing. And us surgeons are simple people. We don't always understand all those things. Yes, we try to say that we think like oncologists operate like plastic surgeons, but we have also our own limitations. Now, I always find it mind-blowing, the amount of data and the amount of things that we're getting from AI. Like Johan mentioned, they can do lots of things for us, especially in radiology and pathology. And it might be, this might be a plan for me to arrange another webinar on AI, because the last one was a couple of years ago. There's lots that have changed recently. They can even predict hormone receptors on mammograms for some tumors on AI in some papers, which I find fascinating. They can predict HER2 status on mammograms. And you look at that and says, how do you even think about those types of correlations, and you get them? So that's something to explore. Fascinating talks by everyone. We have only 5 minutes left. So the next webinar for people, there's challenges across the world. So we have Miriam Mutebi from Kenya talking about breast cancer and ethnic minorities. You have Celine Eng from Singapore talking about challenges in the small breast. We have Ken Utuwoka from England. He's talking about skin nipple and yet flap monitoring in the dark skin, and we're getting a speaker also on scars. And then in October time, we have a more patient-oriented webinar, but will be very interesting for people. So we have Liz Oridian talking about myths in breast cancer, and we're planning a couple of other talks that will be very relevant, because there is lots of things us as clinicians, we don't know really what people talk about and what rumors are there. And there's lots of weird and wonderful things on Google and on social media that you need to tackle. So please join the WhatsApp groups or join the newsletter to be updated on that. Now, Abir, Peter, Johan, Andreas, Isaac, of course, Tim also. Do you have any final comments before we close this? Perfect. So thank you, everyone. You've given up your Saturday afternoon, and great thank you for Ricardo. You've been always with us, Ricardo. And also for Katya for being on the Russian channel. And thank you for everyone that has joined from all different parts of the world. It's great to see you again. It's great to see nearly 450 people that were on a webinar that is not a technical webinar. And for people in the States and South America, have a lovely day. For people in Europe, have a lovely afternoon. For people in the Middle East and the Far East, have a good night. And Peter in Australia, good night. Thank you all.